Hello, good evening, everyone. Can you just confirm that you can see me and hear me well? Anyone? Just raise your hand if you can see me and hear me. Great, thank you. Right, we're just going to make a start because I don't want to delay everyone. Very happy to see you all tonight. So my name is Mina. I am one of the surgeons and associate program director for the PrepMedico FRCS course. We have been running this course for about 4 or 5 years now, 3 times a year. We started with 6 or 7 group of surgeons, but we have expanded to more than 20 faculties now. Tonight, we're gonna talk a bit about the course, about the exam, and we will give you a glimpse with few scenarios about what should you expect during the exam. Okay, I understand that you are here either because you're joining the course, you're doing the FRCS. Maybe some of you, they have sat for that before and they did not pass for a reason and they are resitting again, and some are just sitting for part 1. So we're going to go through that quickly. This is interactive. Please feel free to stop me at any point, raise a hand if you got any question, and we're happy to go through it again. Okay? Can you see my screen? Can someone just raise your hand if you can see my screen? Great, thank you. Okay. Right. Tonight, our session is 3 parts. The first one is going to talk about the exam in general, what it is. Maybe I know that already. How is it conducted? How is it marked? How to approach it? How to prepare for it? Okay. And the second part, we're going to go through some Viva essential scenarios. Of course, we cannot cover everything. We cannot even cover anything today. We're just going to 4 or 5, getting to the most common tips and tricks and how should you approach the scenario in general. Okay. And the last bit, we're going to talk specifically about our course and what we offer and how will it run and all that. Okay. So without further ado, let's go start with that. So the FRCS Section 2 Viva. We'll talk about the GCIE version. There are a few changes when it comes to the GSCFE, the international one, but we'll go to that later. So it is 2 parts. It is Viva and clinical. Okay, usually that runs over 2 days. And with both, it covers the general surgery and the special interest surgery. So for example, if you are breast, okay, that means on the first day, you will get Viva sections, okay, which would be purely breast, and the other half would cover everything, which would be colorectal, upper GI. You can get some breast as well. It's not impossible. We try to avoid that, but it could happen. Everything else is the other half, okay? And on the other day would be clinical, which would be a long case, 1 long case, and 2 short cases. Okay. The clinical would be usually 2 stations, 1 long case, which would take 20 minutes, and 2 short cases, which would take 20 minutes. This is not Bible or Quran. We can change that. So sometimes you can get 2 short cases and 2 short cases. Sometimes you get 1 long case, and if you do well, you can get 3 or more short cases as well. And some candidates in the part reported that it was all about has been 2 short cases and 2 short cases. What you can gather from that clinical bit, we did not go to the Viva yet, that the long case, okay, it's very important because on its own, it has got the same marks as the 2 short cases. The other thing, that the clinical has got more marks compared to the Viva, which indirectly tells you that the most important station in the whole exam when it comes to marks is the long clinical one. Okay? So do not underestimate the long clinical. If you do really well in the long clinical case, and in the Viva you miss 1 or 2 stations, you can still make it up. But if you do really badly and you fail on clinical 1, it would be a hard work to make it up with the Vivas. Okay. When it comes to the Viva itself, okay, there are usually 6 scenarios, 5 minutes each, 30 minutes in total. Okay. Bell at 15 minutes. There are 2 examiners at each table. Remember that one is asking question and both of them are marking you. It's not just one. Okay. And there would be one with emergency surgery, trauma, and critical care. The other station would be general surgery principles, clinical practice. Special interest surgery, that when it comes to the Viva, clinical practice. And then there would be another one, which would be basic principles and academic foundations. Okay. If, so we'll come to that shortly. What's expected from you? You're expected to be at the level of the first day consultant. So, unlike the MRCS or the other exams, you cannot just say, I will discuss it with my boss. You are the boss. Okay? One of the common mistakes usually when you always say, well, I will need to go take that back and discuss it in the MDT. Yes, it's very important to say it, but do not keep repeating that because at some point the examiner will tell you, well, you are the MDT lead now. What do you say? So you are the level of first day consultant. However, it's perfectly acceptable if you get a hard case to say, I will discuss it with a consultant colleague. 50% knowledge and the rest is 50%. And that's very important. We'll go to that later. Knowledge gaps are not the commonest cause of failure. The rest is about how you behave, okay, how you approach, have you got higher order thinking or not? And it is one of the exam techniques to have a question when you do not know, okay? It's like a situation when you haven't seen before. They test how will you approach this case because that's a real life scenario. Okay. Imagine this as if you're discussing with a colleague consultant. It's a mature and confident attitude. And that's very important. That's something you can only get with practice. You're not going to the exam as a candidate who someone is examining you, and you do not try to be condescending. That's one of the pitfalls, and we have seen that before. And usually this used to be the case with candidates who used to be consultants in other countries, and they come to the UK to integrate with the system, and they think, well, we can do that. We know better. Probably you're more experienced than the examiner, which could be true. However, this is not the attitude that you should have in the exam. Okay, the exam is not an education opportunity. You do not go to the exam to learn what you do not know. You go there to be assessed for your knowledge, and that's very important. And also, of course, you do not go then to try to prove that you're wrong, to prove them wrong, or to prove that you're right. Okay, so it has to be mature and confident attitude. Treat with respect, two-way conversation. It's not like a mass yes. Okay, they would like to assess how you think. And process and react to scenario rather than telling the correct answer. And that's one of the other pitfalls, one of the common pitfalls when it comes to the Viva. It's not a single best answer. It's not multiple choice questions. And that's something that some examiners try to back you in the corner and say, well, you've got a patient, for example, and the patient you would like to. So you tell the patient that you need to have a colostomy, you need to have a bag. The patient doesn't want that. What would you do? In your mind, you try to think, would you say yes or no? And you try to answer no, that is my decision, you need to have a leg, or no, okay, fine, I will agree. This is not the attitude that you should have in the exam. Remember that survival. You've got the advantage of being able to express your thoughts and explain your rationale. And actually, as an examiner, I would expect you to explain to me why you do that. And most of the scenarios, the scenarios that the controversial one you get in the exam, they would expect you to say this or that. Doesn't matter. There is no right or wrong answer, but would you be able, A, to explain why did you choose that, and B, involve the patient in the decision making? So it's all about how you answer, not what you answer. Okay. You will have real patients. That's mainly in the clinical when you have clinical findings. Sometimes, especially if it's easier for the venue and everything, they get an actor. They get a scenario which is few pages. They get that few days before the exam, explains them what is the role. We don't call them actor, we call role player. What is their role? What information should they have? What information should they give freely to the candidate? What information should they give only when asked? Okay. What's expected? You need to understand that there is an anatomy of the question, and we'll go to that shortly. Okay. It builds up from easy to more difficult. So usually the first question is not a hard question. It's a question that designed to explore, have you got a scheme to follow, right? How do you approach a case being safe? And you being, as it builds up, it becomes more and more difficult, which gives us few pitfalls. Please do not try to be argumentative in the first. The first question is not tricky at all. And remember, you do not get a Viva station about it. Let's see how you manage cholangitis. It doesn't work like that. It always starts with you've got someone coming to A&E with epigastric pain and they have got vomiting. How would you assess this patient? At that point, if this is the first question, you do not know, is that cholangitis? Is it Brohov? Is it perforated GU? Is it AAA? Okay, so because you don't know, I would like, as an examiner, to assess how would you approach this case. Okay, have you got a scheme, ATLS, CRESP protocol, triple assessment if it's breast? Okay, are you safe or not? That's very important. And how will you reach a diagnosis? Usually in the exam, I would expect the candidate to say the differential. You would say, oh, that could be AAA, that could be BFGU, could be cholangitis. And then I, as an examiner, would pick up that from your mouth, say, oh, you said cholangitis. What is cholangitis? How to diagnose it? And they will take it from there. So that's very important because you do not know what the topic of the scenario is about. You have to be very organized. Okay? Evidence. Oh, sorry. Common things are common. We are surgeons. We're not physicians. Okay? You do not get stars for knowing the most rare thing. Common things are common. If I'm telling you, you've got someone who's coming with an epigastric pain, please, I would expect you to start with A, to know what is the most serious, B, to know what is the most common. And usually the least common thing is very rare and it is controversial and it's provocative. When you try to say, oh, I've got someone who has got epigastric pain, that could be tuberculous osteomyelitis in the back of the spine. Could that present with epigastric pain? Yes. Is that the commonest? No. That would be very controversial. And if I'm the examiner, you start by saying this, I will not tell you that you're wrong. I would be very intrigued to say, really, how would that present? What would that be like? And because you started with that, you do not know, is that the topic of the scenario? Or is it just you became provoked by my answer? So usually you have to start with the common things are common. Evidence. Yes, it is important. It's not so important. And that's one of the common misconceptions about trials and stuff. Everyone thinks that FRCS is about knowing the high-end trials and what are the subgroup analysis for that and what is the most recent evidence. Is it important? Yes. Will you fail because you don't know that? No. No one failed because they did not know the trial in the exam, unless you're a breast trainee and it is a Z11 trial. If you don't know it, you will fail. Breast trainees are a different cohort, so that's a very special group. Okay, they need to know things that general trainees they do not need to know. But anyway, as a general rule of thumb, trials and evidence, they're important to put the cherry on the top to get the full mark in that station in the exam. But it's not a pass or fail. And you will not get asked about these unless you build up from the beginning of the scenario. Okay? Do you follow? Do you follow me so far? Mini feedback. Is it all right? Good. That's great. Thanks. Uh, when it goes on quiet, I don't know whether you're agreeing or my internet is down or what. So good feedback would be great. Right. Structured responses, that's very important. You lose marks. You lose marks for being disorganized in the exam. And recently, I think over the last 2 years, they introduced feedbacks for candidates who failed before. If this is not your first attempt, that's something that you might benefit from. Go back if you don't have not done that already and ask for a feedback. If you did not pass, why didn't you pass? They will give you a copy of your mark sheet telling you exactly why they failed you. Okay. And we have been, as a faculty of the course, we have been with many candidates in the past who did not pass, and we had the opportunity to go through this with them and to work toward their weaknesses. And you would be surprised to find that things that you do not know or you do not think that might have been a reason for failure are actual reason. Things like using scientific jargon when it comes to speaking with a patient. Being disorganized actually is the commonest cause of failure. And lack of structured response, lack of higher order thinking. Feel free to say you don't know. And I say that's very important because the way the Viva is structured is they do not tell you that you have done wrong. If you have been practicing with a colleague or with a consultant where you work, and they ask you a question and you answer it and your answer is not correct, they will tell you, no, try again. In the exam, they wouldn't do that. They will go with you, okay, and dig yourself a rabbit hole. There is an example that I always like to give. That was about 2 or 3 years ago when there was a common scenario that was for breast trainees, okay, about pregnancy, breast cancer and pregnancy. So with breast cancer pregnancy, especially when it comes to first trimester, the thing is that's very tricky because you cannot do surgery and you cannot give neoadjuvant chemotherapy because it's contraindicated. If it's second trimester and later on, you have to give neoadjuvant chemotherapy. So there was a scenario when someone is 10 weeks pregnant and she's got breast cancer. And the question was, how would you manage that? So someone started asking, oh, I can't give chemotherapy. I need to do surgery now. They say, fine. What surgery would you do? They say, fine, I will do mastectomy because I cannot do wide local excision. You cannot do wide local excision because wide local excision will need you to give radiotherapy after, and radiotherapy is contraindicated in pregnancy. That is correct. But then the candidate said, I will do mastectomy. They say, fine. But that pregnant lady, she wants reconstruction. How can you offer that? And then it goes, okay, I will do implant. And then the question is, how to do implant to match the other breast? When it's a pregnant breast, you cannot really match it. And that's a foreign body in someone who's pregnant. So the candidate say, oh, that's fine. I'll take that back. Then we'll do autologous reconstruction. We'll use a DF flap from the abdomen. So the examiner started asking him, will you really do a flap, abdominal flap in someone who is pregnant? And then they started arguing with each other and the bell rang. And that candidate walked away. And the next one asked him, what was the station like? He said, oh, that was very difficult. They asked me how to do reconstruction in a pregnant lady. And that has gone viral. While the actual answer for that has been something very different. This is someone who's 10 weeks pregnant. You need to get her teed up for neoadjuvant chemotherapy. By the time you start that, she would be 12 or 13 weeks pregnant, and then you're in second trimester. That was supposed to be the right answer. The issue here, okay, is, or the lesson to be learned, when you answer something answer something wrong, the examiner will just humor you, will go with it with you, will ask you further questions based on your answer, okay? And as you did not want to say, I don't know, right? You have gone with it trying to find some excuses. And rather than one wrong answer, you ended up making up some answers that they did not exist before. Do you follow? Which I call it, you dug yourself a rabbit hole. That's the spiral of doom, and you find yourself, answering some weird questions. They're not weird questions. That's your answers. Okay. So 3 lessons to be learned. First, if you think you don't know, feel free to say I don't know. Okay. Even if you lose mark for that, you can redeem yourself later. Second, if in your exam, do not try to ask anyone what questions have you been asked, because the question that that specific candidate have been asked are based on the answers that he answered. These are follow-up questions. Okay, they're not necessarily the question that you would be asked. The third lesson, if you have been collecting any feedbacks from previous candidates and they tell you, oh, they have been asked very weird questions, they've been asked this and this and this, and that's beyond the ST4 level, that's beyond the ST5-6 level. Well, take that with a pinch of salt, because they have told you what questions have they been asked, but they did not tell you what answers have they answered. Does that make sense? I hope it does. Do not bluff. And that's very important, especially if you're saying that you're doing an operation that you haven't done before. Examiners, they could tell that you haven't done that. So please just be straight. Thinking under stress, the exam is designed in a way to put you under stress. This is intentional because we are surgeons. You might have a patient who is unwell and you're the leader in theater and you need to make some serious decisions. So you need to be conditioned to stress. This is the list of level knowledge required. This is based on the GCIE, okay? And that's here for general candidates. For the specialist, in your specialty, there is no ceiling for what you need to know. You need to know everything, okay? But if you're a general trainee, you need to know up to ST8 level in all these, up to ST6 level in upper GI colorectal, and up to ST4 level in transplant, breast, endocrine, and vascular. Do not give these branches. Let's say you're a colorectal trainee. Okay, that means if you look at that, 50% at least of your exam will be about your subspecialty. And about 50% is everything else, including academic and the statistics. That's why you have to be very clever and smart when you're preparing for the exam. Okay, 50% at least of your efforts and time should go towards your subspecialty. Okay, for 2 reasons. A, because that's at least 50% of your questions. B, there is no ceiling for what you need to know. But do not go focus on your weakest spot when it is the least meaningful in the exam. Let's say you're a colorectal trainee, you know nothing about transplant. It doesn't make sense when you're preparing for the exam to spend 2 or 3 weeks just studying transplant. You will not, that will not get you that mark that you think you will get. I hope that makes sense. Do you follow? Does that make sense? Okay, guys? Good. Great. Right. This is the marking, and these are the marking descriptors, and this is something actually you will be sent on the email once you register for the exam. So it's not secret in it. So you mark it out of 8. Okay, you get anything out 4, 5, 6, 7, or 8. No one knows how the whole mark works. Or how do you calculate the number of marks? Okay, we've been trying to find out. There no one knows. But what we know, for every station, you get a mark out of 8. 6, 7, 8, you pass. 4 or 5, you fail. Okay. 4 means that you're not safe at all. Actually, you have done some horrible mistakes. 5 means you've got knowledge gaps, your attitude, your higher order thinking, anything of that's not true. Feel free to go through all that. And 6, that means you demonstrated competence. 7, you're working as a good level of competence. 8, basically you made no mistakes. Okay, 6 is all right, but ideally you should aim for the 8, because some stations you might fail, and that's when the 8 will make up for you for another station. Okay, right. This is very important slide. What are the causes of failure? There are 3 causes of failure. Okay, the number 1 is knowledge gaps. That means, well, they ask you about information simply you don't know. The number 2 is poor Viva techniques. And by poor Viva techniques, that means that, well, your lack of organization, lack of your body language is not revealing that you're confident or you can perform at the consultant level. That's very important. And by the way, examiners, they can tell. And we can tell by looking at you. And that's why the most important bit with preparation for the exam is practice and practice and practice. You might think watching someone being asked a question on a video or just watching a Viva, you think, oh, that's an easy question, I can answer it. But once you start answering yourself, you will find that you have poor technique. So you can only know by practice. And we can tell based on your body language whether you cannot remember the answer or you're trying to make up the answer. Okay, I can tell if you know it or no, you forgot it. And the other thing is poor stress management. Okay, the exam is a very stressful condition. You have paid a lot of money. You have been away from your family in a hotel. Maybe you haven't slept or have proper food for 2 days, and you're sitting from the morning amongst a bunch of other candidates who have been trying to revise everything in a very noisy environment. And once they say, oh, that topic, you start remembering, oh, that's something I cannot remember. So it's very stressful. Okay. And it's very easy and very common to, under these conditions, to forget what you already know. Okay. Especially that, as I said before, the exam is designed in a way to put you under stress. Okay. Out of these 3, what do you think? Which one you think is the commonest cause of failure? Is it number 1, 2, 3? Anyone thinks it's number 1? Put your hands up. Okay. Thanks, Annie. Put your hand down. Anyone thinks it's number 2? Okay, that's fine. Thank you. Put your hands down, please. Anyone thinks it's number 3? Okay, right. Okay. Thank you. It is number 3. Poor stress management is the commonest cause of failure that we see amongst candidates. Okay, because the examiners are not there to support you. This is very clear. The examiners are there to put you under stressful condition. The exam conditions are not very favorable, I'm afraid. Okay, and it's very easy to get stressed and to forget some stuff. Poor Viva technique is the second commonest cause of failure. And number 3 is knowledge gaps, actually. So, knowledge gaps that you can overcome by studying. Poor Viva techniques you can overcome by practicing. Okay. Poor stress management you can overcome by your regular practice. You have to put yourself outside the boundaries and being. So that's why we always say it's very important to participate in a course. If it's not this course, at least enroll in a course. And I always say, if you can join as a participant rather than an observer, that would help you better, because then you put yourself under stress and you have to do that many times. So that's why we try to do it every week, so that when it over the period of 3 months, when it comes to the exam, you just feel it's another weekend in the Viva. Okay, so you overcome poor stress management by desensitization, basically. Okay, and you overcome poor Viva techniques by practice. You overcome knowledge gaps by studying. Right. So, how to prepare? The first thing is know who you are. That's very important. You have to understand what are your weaknesses, what's your shortcoming, what should you work on. This is especially important, okay? This is especially important in candidates who failed before. It is very common that you sat for the exam before, you did not pass, okay? And you think because I did not know enough, and you start by working on your knowledge, trying to study more and more and more and more, and you go again and you will fail again because your problem has never been knowledge gaps. Your problem has been your Viva techniques or stress management. Okay, so you need to understand what are your weaknesses. That's very important. As I said, if that's not your first attempt, go for the GCIA, ask for a feedback, for a written feedback. They will email you that. Sometimes they take a few weeks. Assess what you need. Okay, need to understand what's plenty of. You've got plenty of unfamiliar territories. We don't. No one knows everything. And you need to understand what you work on, and you need to plan that spot smart. As I said before, do not just spend 2 or 3 months working on transplant when you're a colorectal trainee when you might sit for the exam and not seeing a single transplant case. Okay, identify the easy way that suits you. Some people are better with practicing, some people are better with themselves. There are very few ways now that have been done. So, few things that have been seen with candidates and have worked before. Number one is talking to the camera. You've got your smartphone with you, turn on the front camera, answer, and assess yourself. That's one thing that you can do. The other thing is practicing with colleagues. The other thing is mock exams. And more recently, AI. They are pretty good in examining you and playing examiner, but be careful with that. As I said, join one of the courses. I would say that's very important. You might think that you might not need that. You might think that you can answer that till you start answering that. And then you need someone to tell you what are your problems. Okay? Invest and sacrifice fully. FRCS exam is very easy to pass, it's very easy to fail. Okay? But it requires hard work. As I always say, studying for the exam is not something you do in your spare time. It's something you spare time to do. If you are someone who've got busy work, busy life, children waiting for you to come home, okay, and you've got lots of clinics, theaters, logbook you need to do, and you would expect to go home after a busy day, have dinner with your family, sit with your children, and just for half an hour before you go to bed to study, that will never happen. Okay? From my experience, the best way to prepare for the exam, after you finish your day, if you finish at 5 p.m., do not go home straight. Spend another 30 minutes or 45 minutes in the library. This is a perfect environment when everything is quiet, no one would bother you, as if you had a sick patient that you had to attend of the day. And if you do that religiously every day, you will find yourself finding a lot of time, and then you can go home. Mubarak, I see your hands up. Have you got a question, or was that a legacy hand? Mubarak Rahman. Can you hear me, guys? Yes. Okay. So, okay. So I would assume that's a legacy hand then. Let me put that down. Okay. Anyone has any questions so far? Are you following? Yes, I'll take that as a yes. Right. So yeah, this is the best way to try to study for the exam. It's to spare the time to do it. Don't try to do it in your spare time. There are no shortcuts. Okay, it requires hard work, and you need to study very hard for that. There are no shortcuts. Let me go through that question. I've done everything about the exam itself. Okay, there are a few slides that I would like to go through the anatomy of a question before we start giving you a few scenarios. Does anyone have any questions so far about anything that we discussed? Okay, right. Anatomy of the Viva question. That's very important. When you need to understand from the examiner perspective, if you are the examiner, how to conduct the Viva, how to ask the questions, and how to mark the candidate. So, as we discussed, you just start with an introductory question, okay, which is when you give the candidate a presentation rather than a condition. Okay, it's not too challenging. It's designed to be easy. Any question from the examiner here are to steer you to the right direction, not to challenge you. And that's very important. At this stage, it's not challenge. Do not try to challenge the examiner. And I would say, don't try to challenge the examiner at all. Not at this stage, not at a later stage. For example, as I told you, they would tell you, you are the consultant on call in a weekend. There is someone who came to A&E unwell. I've got gastric pain. How would you assess him? And then they would expect you to go through, follow a scheme. Things like I would go to see the patient myself. I follow the ATLS protocol, CREST protocol, sepsis 6, history examination, and to go through the differentials. As we said, common things are common. Okay, if it's a trauma case, you've got someone who's in a road traffic accident, has been hit by a motor vehicle, and he's unwell. How would you assess him? You say, I would go ATLS protocol A, B, C. I will do that. Okay. I, as an examiner, need to know that you are someone who is organized, have got a scheme they can follow. Okay, who is safe. Okay, who has got situation awareness, which is very important at this stage. Are you managing the patient in the right place? If the scenario is you are seeing someone on the ward who is day 2 post-tritemia and they are unwell, do you realize that that patient might need to go to HDU? If I'm telling you your registrar has seen someone who's trauma and they're unwell, I need you to say, I would go down myself and see the patient. It's not a phone call. You need to discuss cancer cases and complex benign cases in MDT. Involve other teams. That's very important. We are all good in that when it comes to other specialties. So if you are a colorectal trainee and I get you a Burhav, the first thing you will think about, I'll discuss with upper GI colleague. If I tell you a complex scenario about someone who's got breast implanted, they got infection, the first thing that will pop in your head, I will call the breast surgeon. But there are a few things that we miss, like you've got someone who has got hypercalcemia. Would you involve the endocrinologist? Someone is unwell, you need to involve ITU, HDU, call the operating surgeon. Any scenario that starts with your day 1 consultant or that's your first on call, that's your first theater list, and you got a complex case, please remember to get help from a senior colleague. Okay? Bad news. Anything you answer correctly here, you will not get mark 4. I'm sorry, but if you expect to pass the station in the FRCS because you know the ATLS, ABCD, no. Anyone should know that. However, you will fail if you don't know that. And that's when some confusion comes to the candidates. You think I've answered well, but I still failed. Yes, because this is not the information I'm testing you. I'm testing how you approach the case. And as I told you, you do not know what the scenario is about. The scenario might be about splenic rupture, but I wouldn't ask you what are the grades of splenic rupture, how you manage it. I would start by saying, you've got someone who came in a trauma call in a road traffic accident. Okay, and I would expect you to go through the A, B, C, and when it comes to the C, we'll go through it. And once you see the CT scan showing splenic rupture, that's here the bread and butter of the scenario. But do not expect to pass just because you don't know the ABC. But you will fail if you don't know the ABC. Okay, so be careful here. The second stage of the Viva is complication decision making. That's based on previous questions, answers. There is a diagnosis here. As I told you, it's splenic rupture or it is cholangitis. Now, we started to talk. How will you manage it? Okay, the examiner intends to know what you will do exactly as a consultant. Situation awareness is not tested, so please at this stage do not keep repeating yourself, which is one of the common things that we see among the candidates. They keep saying, well, it's a burhav, I will call the upper GI surgeon. Yes, you said that. Okay, and then I'm asking you, what if the patient becomes unwell? I will call the upper GI surgeon. Yes, I know, you said that already. Do not keep repeating that. Or when you keep repeating, I will take that patient to the MDT. I will need to discuss it in the NDT. I will need to rediscuss it in NDT, especially in your subspecialty. If you're a breast and I give you a complex case and you keep saying, I'll need to discuss it in the NDT, at some point the examiner will tell you, you are the NDT. Stop saying that you take the NDT. So it is tested. Your management, it's tested at this stage, not the situational awareness, okay? You need to support your answer with evidence as possible, okay, either from the BSG, if it's an upper GI, BHS, British Hernia Society, ABS for breast, nice guidelines. You will be asked to consent a patient, okay, especially if it's the long clinical case. Usually there is 2 minutes at the end to consent the patient. Please remember to consent the risk of the figures. One of the most annoying things is you say, oh, there is a risk of bleeding or infection and risk of general anesthesia. I'm not asking you as an FRCS candidate to consent the patient for a hernia repair, for example, to tell me there is a risk of recurrence and there is a risk of strangulation, there is a risk of bleeding. No, I want you to quote, there is a risk of recurrence, which is about 1% per year. I want you to quote what is the risk of strangulation if you don't do that. What are the quoted risk of nerve damage and what are the predisposing factors? So this is what I expect you to do or to know as an FRCS candidate. Consenting is about quoting figures. It's not about naming the complications. Okay. The other thing is avoiding medical jargon. You would be surprised about the amount of candidates who failed. And when we go through their feedbacks, we find they have used medical jargon while talking to the patient. Okay, you lose points for that. The other thing is you need to be able to show ability to discuss alternative treatments. At some point, you will find the patient tell you that he doesn't like the treatment that you offered. He wants something else. Would you do it? You are offering the patient wide local excision, but she wants to have a mastectomy. What would you do? The wrong way to do it is to say no. She needs to have wide local excision. No, wide local is better. Or no, she can. Oh, yes, she can have mastectomy. The patient is always right. She can do whatever she wants. I'm not asking for your executive decision. I'm checking, are you capable of running a consultation with the patient, involving her in the decision making by explaining the pros and cons of each option and discussing the ideas and concerns of expectations of the patient and addressing them. That's what I try. Whether the patient decides for mastectomy or wide local at the end doesn't matter, but are you capable of running this consultation? Okay. Once we pass that stage, once you go ask about future prospects, trials, high-end things, complications, unexpected findings, controversy in the management, if you reach this stage, congratulations, you pass the stations. Even if you don't know the answers there, you will still pass. You will not get the 8, but you will still pass. And that's when I told you that the evidence is important, but it's not that most important. I have known breast trainees who have spent the last 2 weeks before the exam just getting through a very long list of trials, knowing, oh, this is a trial for that, this is a trial for that, this is a trial for that. You will not be asked about the trials unless you go through the whole station. Okay? So trials are important to get a full mark, but you will not pass or fail just because you didn't know the trials. Okay? Any questions? I've done with the first part of my session today, guys, which is about the exam. Anyone has any questions about the exam? Good. It's either you understood everything, or you don't have any questions, or my internet connection is very poor. And you cannot see me. I've been talking to myself over the last half an hour. Okay. Right. I've got a few scenarios to go through. I would like some volunteers. There is no right or wrong, guys. I'm not testing your knowledge. I will be testing your, we will be discussing them. And it's I'm not expecting anyone to know everything. You're here, or you're preparing, so you're here to know what you don't know, not show off what you know. So that's all non-judgmental here. I'm just using that as opportunity to just to show what we have discussed. Right, Ashraf, you volunteered for the first one. Ashraf, can you turn on your mic? Did you change your mind? Ashraf Ahmed?
Hello?
Hi, Ashraf, can you hear me?
Yes, I can hear you, sir. Actually, I'm driving now, but my question was before starting the reviewing some Vivas, I was going to ask you, sir, about the other structure, GSFE, the international FRCS, because I'm going for international type. You said in the beginning you will tell us some
we cover
light
both.
about this one.
Yeah. So we cover both. There are some differences when it comes to the international one, when it comes to the GCIE one. First one is the specialty. I think we are all general. There is no subspecialty when it comes to that. And that's why we go through all the course there as usual, but the mocks are different for the GSCCFE. Okay, and we've been running that separately, I think, over the last 2 or 3 years, Ashraf, and it has been very successful. I think the last 3 gold medalists from the GSCFE were our candidates, actually. So there are a few differences. The core knowledge remains the same when it comes to colorectal, upper GI, breast. What you need to know is the same that you need to know. It all depends on the subspecialty, because I don't think you have subspecialty when it comes to GCSE, and which is reflected on the statistics, the academic station, and the mocks at the end. But otherwise, through the 3 months, it is exactly the same. If you'd like to know more, I would encourage you to contact Manny, Mr. Catherville, Manny Camden Catherville, the course director. He has been running that GSFE, and he will tell you exactly how we can change that to accommodate it. So that's one thing. The other thing, I think you already have done your homework, Ashraf, trying to know exactly which one is better for, or which one suits you better. Is it the international one or the GCIE one? Because there have been some discussion about, can you do CESA with the GSFE? I have known one of my colleagues who has done the international one, and when he moved to the UK, tried to do the CESA, they asked him to resit to the GCIE. So as long as you are clear which version you're taking and why you're doing that, that's absolutely fine. That's outside the scope of today, but we're happy to talk through if you need. When it comes to preparation itself, the 3 months or the studying is the same, but it's not subspecialty in general. I think it's all general, and the statistics is slightly different. Okay. Any other questions? If you have got any specific questions, Ashraf, please text Mr. Catherville, Manny Camden Catherville, the course director. He's great. He will happily answer you. Any questions? Right. Any volunteers? Okay. And sorry, how do I pronounce your name?
You can call me Gateway. Gateway.
All right. Yeah. What's your subspecialty?
Actually, I'm the same as Ashraf. I'm sitting for the GSCFE.
Excellent. Right. Okay.
I'm currently in colorectal training.
Okay. That's great. So we're going to start with the scenario now, okay? I will be the examiner. It is a long Viva. It's not clinical. So in that setting, I'll just ask you a question, you answer me. And when the time is up, I will tell you, and then we can discuss together your answer. Okay?
Okay.
So, okay. In your first on-call shift as a consultant over the weekend, you have been asked to review a patient in the ward. The patient had an emergency laparotomy and heart mass procedure yesterday by your colleague. The SHO is concerned as the skin around the colostomy is swollen and red. How will you manage this patient?
Okay. I will assess the patient myself, as I think that the patient requires a more senior person's assessment. First, I will take a focus history regarding the indication for surgery, whether it's for a benign or malignant case. And I would like to know the patient's background, what is his or her comorbidities that put him at risk of any complications. And I would also like to have a look at the intraoperative notes. Was there any difficulty when they bring out the stoma? Was there any other complication intraop, such as spillage of feces, or whether there is bleeding, etc. After getting the histories that I need, I will assess the patient. First, I will assess the patient's general condition, whether he's in sepsis, having difficulty breathing, dehydration, warm to touch. I will have a look at his vital sign, whether there's any hypotension, tachycardia, fever, and also the urine output. On assessment of the stoma, the redness surrounding the stoma could be a few things. One is I would also like to assess the color of the stoma itself, not only the peristomal skin, because the peristomal skin, which is red, may be related to a stoma which is necrose, gangrenous,
What
or
would you like to check on the stoma? Which things are you checking in the stoma?
okay, I would like to assess the color of the mucosa, whether it's a pink or dark, whether it's shiny or it's dull in color. And I would like to put in a specimen tube and shine in a torchlight so I can see beyond what is at the skin level.
Anything else?
I would like to assess the output, whether it's already functioning, and the general condition of the abdomen, whether it's distended, showing some signs of obstruction or any signs of peritonitis.
Anything else you'd like to check with the patient?
The drain color, whether it's there's any bleed, feculent or any pus.
Okay. So the SHO is telling you that while you're seeing the patient, the nurse comes and tell you that the patient is musing 10. Do you know what is Muse score? Do you understand what is Muse score? Muse, MEWS, or News score, NEWS.
Yes. Early warning sign.
Muse score.
Yes.
Okay.
Yeah.
And 10, would you consider that high or low?
Well,
Okay.
in the place
Do you know what the items of the news score are?
Yes. It basically assess the patient's vital signs such as heart rate. If the heart rate is maybe more than 100, then the score will be higher. Heart rate, blood pressure, temperature, and the respiratory rate.
What is the value of news score gate? Why is it designed?
It's designed as an alert system. When it reaches the red color, it triggers more critical care, which may suggest that patients need a higher level of care, and something needs to be done.
Right. So if the nurse is telling the news score is 10, which is very high, what's the question that you will ask her next?
What is my management next? What would I do?
What question would you like to ask the nurse about?
Okay. What is the color of the stoma? Is it black?
The nurse. So the nurse doesn't know anything. She's told you, no, I don't know anything. I haven't examined the stoma. I just want to tell you, I'm warning you that the patient's news score is very high.
Okay. what has been done for the patient. Was there any fluid resuscitation being given by the SHO, or was there any?
Do you want to do any? Nothing has been done. Do you want to do anything?
Okay. So I would like to tell the nurse to give oxygen resuscitation, ensure that the patient is being propped up, ensure that the patient has lines running, and give 10 ml per kg normal saline fluid resuscitation.
Would you like to know why the patient is using high? What are the parameters? Would it make a difference? So you should ask the nurse why is he using high. Is he using high on what? So it's telling you that the heart rate of the patient is 140. His tachypneic at 35. Okay. His blood pressure is 90/50.
The patient is obviously unwell, so I will resuscitate.
The patient has got a drain, and the drain is empty. And answering your question, the patient had emergency Hartmann and laparotomy for perforated diverticulitis. When we check the stoma, the skin surrounding is very fiery, angry red. The stoma itself is healthy. Okay, mucosa is pink. There is no output.
Okay, so I will first resuscitate the patient according to the CRIPS protocol by giving oxygenation, fluids, antibiotics, pain analgesia. And in this patient, I'm worried of necrotizing fasciitis surrounding the stoma skin. This is a surgical emergency.
What is necrotizing fasciitis?
It is a severe form of soft tissue infection, which is spread along the fascia. It has a different name to when it affects different areas. For example, if it affects the perineum, it is called a Fournier's gangrene. The risk factors for necrotizing fasciitis are patient-related factors such as immunocompromise, diabetes, obesity, use of chronic steroid use, and in her scenario, the risk factor for her could be sigmoid diverticulitis, which is a contaminated surgery to begin with, and being an emergency situation. So I will also.
What is the causative organism?
The organism is usually divided into necrotizing fasciitis type 1, 2, or 3. It can be purely due to Clostridium difficile. It can be due to a mixture of organism, Streptococcus in origin, and polymicrobial.
Okay, so you're suspecting necrotizing fasciitis in the patient's unwell. What will be your next step of the management?
So I will explain to the patient and the patient's carer that this is the clinical diagnosis, and I do not think that arrangement for any investigation will change my management. I will advise her for surgery, which is debridement of the necrotizing fasciitis skin, and I will also need to relocate the stoma. Probably I will choose at the opposite side. I will explain to her the indication of the surgery because this necrotizing fasciitis is life-threatening, and what I will do is I will debride and lay open, so she may have a wound to take care of.
You're got now the patient asleep on the theater table. You're scrubbed. Talk to me what you're gonna do next. What are the steps? So you've got a blade in your hand. The patient is asleep and intubated. What are you gonna do after draping?
Okay. First, I will make an incision at the area of redness. This is to determine the depth or spread of the infection, whether it's a pure just a cellulitis or it is really a necrotizing fasciitis. If it is necrotizing,
what's the difference? What was happening that's going to tell you the difference? What are you looking for?
So I'm looking for a foul-smelling discharge. Usually, is a cloudy fluid. and the tissue is dull, red, black in color, gray in color, not bleeding, and there's crepitus, there's air, I can feel the crepitus, and it spreads to a wide area. As compared to
Okay.
cellulitis, there is no necrosis of the soft tissue.
Okay, so you've done your incision and you could file there is no bleeding. The tissue is already looking grayish. So you're going to debride all the area. What is the extent of your debridement, Cake? Sorry, I'm saying your name right, Cake.
Yes, correct.
Okay.
Yeah.
What's the extent of the debridement?
I will extend until I see bleeding edges. The fat tissue are shiny, and
So you're going to take all the tissue till the edges are bleeding.
yes, but I
Okay.
do understand that necrosis fasciitis usually it can progress. For example, the next day when I do the wound inspection, the edges that I thought was healthy may become gray. So in that case, I may need a repeated debridement.
Okay.
Yeah.
So right now, let's talk about our patient. You have done the debridement. Now you've got a very big area. Okay, about a disc which is about 25 centimeter in diameter of raw tissue, but it's all bleeding, it's all healthy, and you've got a stoma in the middle of all that. What are you going to do next?
I will relocate the stoma because it's going
You're
to
going
be.
to put it, the stoma now is in the left iliac fossa. Will you open the laparotomy and do it put it in the right iliac fossa? Or what
Yes.
you will do? Talk to me. I'm a simple breast surgeon.
Okay. I think that would be my choice of surgery. I will open back up the old incision, disconnect, pull back down the end colostomy. I will need to mobilize the splenic flexure and the transverse mesocolon in order to be able to bring it to the right iliac fossa without any tension and make sure
This
that
is a really long operation. How do you think that would take you in a patient who is extremely unwell and hypotensive?
I'll probably do a stage surgery. In the case that he is really unwell during the op, I will focus more on the sepsis. I will probably staple off the end colostomy, drop it down, and probably on subsequent wound inspection, assess whether I need to re-debride or not. When patient gets better, I will re-debride and mature the stoma properly.
Okay, right. What about that big hole that we're left with? With the debridement, you've got a very large area of raw tissue. What are you going to do for that?
For the first few days, I will do daily dressing. When the wound edges are better, healthy, then only I will do a vacuum therapy, vacuum dressing. The reason why I do not do vacuum dressing immediately is so that I can keep on assessing the wound on the first few days.
Yeah. And what are you going to do? So you've done that. So you have relocated the stoma. You put a dressing, and then shall we wake the patient, put him back to the ward, or what are you going to do next?
Patient, I will talk to the anesthetist. I will recommend that this patient be managed in the high dependency unit or an ICU, and see what the anesthetist's opinion, whether they can extubate the patient or they agree that the patient need intensive monitoring.
Okay. So you're having a discussion with the SHO in the theatre coffee room after, while you're writing the notes, and he's asking you, could we have done any imaging that would help us to diagnose that necrotizing fasciitis? Is there any role of imaging in diagnosis?
Okay, we can do a CT scan.
What will the CT scan show?
CT scan will show the edematous thickening, a lot of fat strengthening, and also air tracking along the subcutaneous
Have you
tissue.
ever done a CT scan for a patient in day 1 post-laparotomy?
Yeah.
Even if the patient is very well, it will show exactly what you're saying. Free gas, edematous tissue, stranding. You're dealing with a patient who had just had perforated diverticular disease with fecal peritonitis yesterday and is recovering from laparotomy. Do you think the CT scan would show anything different? I would be surprised. If I do not see edema and free air in the abdomen, probably that's a CT scan for the wrong patient.
Yeah, true. So I know there's a scoring system. It's
We're still
called
in the we're still in the topic of the imaging, please.
imaging. Okay.
So you told me CT scan. So do you think the CT scan will show necrotizing fasciitis? Or we're just wasting the time of the patient, wasting the spacious time, and we're just giving a contrast for no reason? And if it's not, do you know any other imaging that could help?
Okay. Actually, I'm not sure of any other imaging. But I will try
It's
for
okay.
maybe.
That's fine.
Okay.
It's okay. You've been talking about score, Cake.
Yeah.
What
so
score is that?
it's called a lyric score.
Okay, what is that?
So it helped the clinician to diagnose the necrotizing fasciitis with more confidence. With a higher score, the diagnosis is more likely. So it consists of parameters like the tachycardia, fever, leukocytosis, and I'm not sure about the rest. Sorry.
Thank you. Thank you very much. Thanks.
Okay.
That's all done. What do you think?
There's knowledge gap, especially for the new score. I agree, because I do not use it in my area of practice.
Where do you work?
In Malaysia.
Malaysia.
In Malaysia.
Okay.
Yeah.
Okay.
Yeah.
Right. Okay. And let me tell you what I think. Okay. First of all, thanks for taking the courage to do that. Okay. Second, I can tell that you experience it. I can tell that you managed cases like this before. Okay. That's what I tell you. You know what you're doing. You know how to diagnose it. You still you know the knowledge. What you're lacking is proper awareness of the UK system.
Yeah.
Okay. The FRCS exam is not just a surgical exam. It's a UK surgical exam. It tests everything according to the UK guidelines and UK practice. So that's something you need to know. Okay. There are a few things. What I would say, do you remember when we talked about the anatomy of the Viva question? Let's put that scenario, and that's not for you. You performed well, by the way, for your first Viva. But let's put that measure against what we discussed. So I told you that there is a patient here who's unwell, day 1 in the ward, because he's got redness around the stoma. Okay, and he had laparotomy yesterday. The first thing, this is a situation, so you should approach it with a very organized, with a clear plan. You should start by saying, I will follow this patient. I would go see that patient myself, as you said. Okay. I will need to assess the patient according to the CRISP protocol. That's the first thing you should say. And you should know what is CRISP. CRISP, sepsis 6, ATLS, you need to know by heart. Okay. What are the elements of the CRISP protocol, A, B, C, D? So you should automatically start by saying, I will assess the airway, breathing, circulation, all that. Do not expect me to skip this. If I want you in the exam to skip this, I will tell you. That's fine. You have done all that. Okay. Unless I tell you that, do not assume that I don't want to know about it. That's one thing. The other thing, use the score. You mentioned that something definitely you need to know for the exam. Okay. Situational awareness, you should have managed that. The patient is unwell. The first thing you need to do is to call ITU or to call outreach. You need to call for help. You're not going to manage a critically unwell patient on your own or just with an SHO. Okay? You need to call for an outreach. You need to call ITU. Okay? You need to call the operating surgeon.
Oh, okay.
You need to go, okay? You're not the operating surgeon. Maybe he's around. You need to call the operating surgeon. You understand all that. You need to go through the operation notes, and I want you to tell me what exactly you're looking for. You want to know the indication. Have there been any events? Is there a drain or not? Okay. Have there been any challenges? You need to know the patient's comorbidities, but you mentioned that. Okay. And every information I tell you in the scenario is for a reason. For example, I told you that the stoma is healthy. That's not stomach necrosis. I told you that the drain is empty. Okay, to tell me that that's not bleeding, that's not postoperative bleeding. Okay, so this is the situation awareness and the management. This is the first part of the Viva that you need to get there. And that's when we test, have you got organized thinking or not? Okay, and ideally, this should take like a minute or so. Okay, ABCD, CRISP protocol. Once I told you that the patient is unwell, low blood pressure, high heart rate, tachypneic, that patient is septic, isn't it?
Mm.
The first thing is, I will start sepsis 6. You have to mention that. Okay? This is how you save the patient life by the CRISP protocol and the sepsis 6. And you want me to tell you the sepsis 6, what are the sepsis 6? 3 in and 3 out. You need to tell me that you're going to take lactate. You didn't tell me that you're going to do any bloods for the patient.
Oh yeah. Yes.
Okay.
Yeah.
Right. And by the way, and for the exam, do not assume that the examiner knows that, oh, of course I will do blood. I'm sorry, if you didn't say it, you didn't do it.
Okay.
I always say, those who live in the UK will correlate to that. Think of the FRCS exam as the driving test in the UK. We all have been driving in our countries for years and years, 20 years. But once you move to the UK, the first thing you will do is to sit for the driving test with an examiner sitting next to you. And they need to see you checking the blind spot, checking who's crossing the street, doing the indicator. You do that inherently, subconsciously. You always check the blind spot. But the examiner wants you to look like this. Show it.
Okay.
Unless you tell me, this is the same for the FRCS. Unless you tell me what you're looking for, I will not assume that you do that.
Okay.
The examiner does not work for your favor. He's not there to pass you. He will not assume you that you know. You didn't say it, you didn't do it. Very simple as that. So I will call out the reach. I will call out RTA. The patient's sepsis, I will do sepsis 6. I will do full set of bloods. I would like to check for full blood count, hemoglobin, white blood cell count, CRP. Okay? And then I will proceed with local examination of the abdomen. I need to do first, is the abdomen tender? Is it surgical abdomen? Okay. Are there any signs of bleeding? I will examine the wounds. Is there any wound dehiscence? And then I will do local examination of the stoma itself. I need to examine from surrounding, the stitching, the mucosa, as you said, the inside, the contents, if there any separation or not. And then I will tell you there is a fiery red. What's your differential? And you got that right. The first thing you should think about is neck fascia. Okay. And any other differential diagnosis that you say, which is not neck fascia, I, as an examiner, will challenge you. If you say, oh, that could be postoperative bleeding, I'll say, well, if it's postoperative, how can the patient get postoperative bleeding with an empty drain? And that's when one of the other techniques shows up. Okay, don't try to justify the mistake that you said.
Yeah.
Just say no, probably it's not. That's you did not do that, but I'm just saying that. I'm putting that as an example for everyone. No, do not try to justify it. Okay, no, it's not. The commonest here is neck fascia. As you said. Okay, then I asked you if you knowledge of what's neck fascia, how you diagnose it, all that. By the way, once you suspect neck fascia, you do exactly as you said. You just take the patient to theater. Okay, if you need to do imaging, we do not stop that for the sake of imaging. Once the word neck fascia came across your mind, you take the patient to theater.
Okay.
Okay. There is no role for CT. If you need to do imaging, it's MRI.
Oh, okay.
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 Do we do that routinely? Absolutely not.
Okay.
Okay. It's more for academic, but the only imaging that would show if it's neck fascia, no, it's actually MRI, not CT. Okay. And that's, again, that shows here one of the techniques. When you said this is CT, that's the wrong answer, okay? I didn't tell you, no, that's wrong. I told you, okay, show me how the CT scan will show the neck fascia.
I see.
Okay?
Okay.
And then rather than saying, no, that's not, I take that back. You said, oh, it will show just free gas and it will show edema. It will show free gas and edema anyway for day 1 post-laparotomy.
Yeah.
That's why whenever anyone has got post-operative complication in day 1, whatever that operation is, if you go to radiologist, ask for a CT scan, those who practice in the UK will correlate to that. The radiologist will say, no, I'm not going to do it. What are you looking for? Free gas? It will be there. Edema? It is there. Stranding? It's there. Free fluid? It's there. Okay? So I cannot really give you any answers based on the CT scan. Okay? Something else you forgot to mention. Before taking the patient to theater, you need to inform the ITU.
Okay.
That the patient is unwell. You need to inform the anesthetist. Okay? And something else. Any necrotizing fasciitis operation is a staged operation. We never close the patient in the first operation. We never do that. It's always, we will always relook. So never do you definitive surgery in the first one. Why I'm telling you that, Gaik? Because you do not know what is the actual extent of the neck fascia. What we do, you debride the patient, you close it with vac dressing, and the patient, you do not extubate the patient. The patient remains intubated in the ITU for 48 hours. And then you had to take the patient back to the theater, remove that to see. You might find actually there is more necrosis. You need to do more debridement. Okay? And then once it's, but if you find that stable, there is no more necrosis, then you can, first you can assess what is the extent of the tissue loss. You can assess the situation. And more importantly, the patient has been ITU for 2 days. He's been stabilized now. He can withstand a longer operation if you want to relocate the stoma, if you want to do anything like that.
Yeah.
But you do not plan the definitive surgery in the first operation in neck fascia. Okay? No, we never relocate it. What you need to do actually, take the stoma, staple it, put it inside, debride, and with neck fascia, you remove all the unhealthy tissue. You do not think what that tissue is or how you reconstruct it. That's not what you're thinking about now. You just want to get rid of that, and then vac dressing, stabilize the patient goes to the ITU. 48 hours, you have to relook. Okay? And this is the second part of the Viva. And then the third part, when I start asking you about the imaging and the L-Renic score, which is a laboratory risk indicator for necrotizing fasciitis. L-Renic score. That's what we call it. It's quite niche. We do not usually use it. It's, as you said, it is something that we use to help our clinical decision. Okay? Which is this here. Any question about that scenario? Well done. Thank you. Any questions? I hope that gave you a flavor of how the exam would be like. By the way, I've been a very nice examiner. I do not expect them to be as nice as this in the real exam. Any question, guys? Okay. Any takers for the next scenario? Any volunteers?
Can I ask one question?
Sure, Ashraf.
When I mentioned the learning score, they will ask me the criteria, the data, like if the score is below than 6, from 6 to 7, or just a mention, like I will follow the learning score and then I will assess according to the score.
So Ashraf, as I discussed with Gaik, I did not start with that. This was the last question in the Viva. And you will only get to that once you go through the question. If you know the L-Renic score, you will get 8 out of 8 in that station. If you don't know it, if you say, no, I actually know the name, but I don't know the parameters, or I do not know how it's used, you will not fail. You will not get the 8. Don't get me wrong, but you will not fail. So that's the third part. That's the third stage of the Viva. Okay? When I'm asking you a very difficult question, I have to ask you a very difficult question. Otherwise, everyone will get the full mark in the Viva. And that's not the case. We'll go to that later. The pass rates are not the brightest. That's for that reason. Actually, the published pass rates amongst non-UK trainees in the FRCS is something around 30%. 70% fail. So, no, I have to ask you a difficult question. Sorry. Yes, you will need to know that to answer that. But will you fail if you don't know it? No, you won't fail. This is, as I said, it's just the cherry on the top. Okay? But that's a good question. Thank you. Anyone has any other questions? No? Anyone would like to try the luck with the next scenario? Okay, if you don't volunteer, I will choose. Hussein. Hussein, have you got a question, or
Yeah.
will you kindly volunteer?
I'm a volunteer.
Great, thank you.
Thank you.
Right. So, Hussein, you are in the general surgery clinic. You've got a 76-year-old patient, male, brought to you by his carers, presenting with recurrent UTI and foul-smelling frothy urine. Okay? He lives in a care home, has dementia, but otherwise fit and well. Do you need me to repeat that again?
No, I'm fine.
Okay. So how will you assess this patient, Hassan?
So as I'm a day one consultant, I'm gonna approach this patient, taking full history, a name, age, sex, any as you told me, his past medical history, including he's a dementia patient. I'm gonna ask, does this patient communicate well?
Well, he's all right. He can answer, but he cannot retain information. The carers tell you that he's a full-time carer. He's a full-time patient. He has got Alzheimer. Okay. He is usually care as a bedridden, and they have to carry him to the chair, and he stays in the chair all the time.
Okay, so I'm gonna take a full history from the carer mostly regarding his performance status, what's past medical history, what's past surgical history. Regarding this complaint, I'm gonna assess the onset, course, duration.
So, what do you like to know, especially about this complaint, Hassan? I can tell you.
So, I'm gonna ask if there is any special history regarding the urinary system, like.
So I'm the carer now, and I will answer your question.
Okay.
So it started about 9 months ago. They noted that the urine color is slightly darker, especially when they're changing his nappy. He doesn't have a catheter, but he just wear so the diapers all the time. So when they care about him, when they change it, it's very dark, okay, and it's foul smelling.
Okay. Is there any past surgical or medical history regarding the genitourinary system, like previous history of UTI?
So they have called the GP, who has done a urine analysis, and they found that he has got high white cell count, and they have done a urine culture as well, and it has grown some bugs.
What's the organism exactly?
They're not sure, but they're going to check that and come back to you.
Okay. Is there any previous
what is the commonest organism for UTI, Sam?
Just to know, does this patient takes any antibiotics?
In general, I'm asking you now. In general, what is the commonest organism responsible for UTI?
To know just if the patient takes a course of antibiotic regarding.
No, that's fine. I get that. I'm the examiner asking you. Do you know what is the commonest organism for UTI?
E. coli, yeah.
E. coli. Yeah. It has grown E. coli. That's correct.
Yeah. Also, just to know, is this E. coli sensitive or resistant to oral or IV antibiotics? Just to know.
They're telling you that the GP has gave him 4 courses of antibiotics, but it keeps resistant. And when they checked the culture, they said that it has grown what you said, which is E. coli, and there has been mentioning of Streptococcus fecalis.
Streptococcus fecalis.
Mm.
Okay. Regarding the organism, as you told me, the patient took 4 courses of antibiotics before. Then I'm gonna ask regarding. Is there any past hospital admission for this reason or for any other reason?
No.
Okay. Does this patient take any medication?
He takes Ramipril for high blood pressure.
Yeah.
That's all. And
that's all, yeah. Okay. So then I'm gonna examine the patient regarding. I would do abdominal examination.
Is there anything else you'd like to know from the history?
Yeah. I would like to know if there is
So if
any.
in the exam, if it's a long clinical case, I would wait you to finish with the history then, and that you're happy. Then we're going to proceed to clinical examination. I'm not assuming that you're missing anything, but I'm just checking that you're happy with the history, or is there anything else you'd like to know?
So the no.
Oh, it's okay. Okay. So clinical, just to save you time, clinical examination is unremarkable. It's soft and lax, no scars, no problems at all in the abdomen.
Okay. Yeah. Then I'm gonna order blood test, including full blood count, urea, and electrolytes.
What's your differential? What do you think is going on, Sam, here?
Okay, as you told me, my main concern here, as this patient is old and he's, let's say, old age with mental comorbidities, my main concern is, as you told me, chronic urinary tract infection. Also regarding, I would consider, I would keep my mind open toward another differential diagnosis, like if there is any colovascular fistula.
Okay, of course. So why would the GP send someone with chronic UTI for a surgery clinic unless he's suspecting colovascular fistula, isn't it? Okay. What are the causes of colovascular fistula?
The most common cause is diverticulitis, which causes a fistular connection between the colon and the urinary bladder. Also, any past surgical history, like surgical trauma or iatrogenic, regarding urosurgical procedures, also malignancy,
is colovascular fistula, the vertical colovascular fistula, is it more common in males or females?
I don't know.
Okay. I will tell you, I'll give you a clue. So that you would only suspect a colovascular fistula female if she had a hysterectomy. Why is that?
Because the manipulation during the surgery.
No, it's just because anatomically the uterus sits between the bladder and the colon.
Yeah, anatomically. Yeah.
So to get a colovascular fistula, you need to get the uterus out of the way, isn't it? Okay.
Yeah.
Right. So it's more common in males, and you can only see in females if they had hysterectomy. Let's go back to our patient here. So colovascular fistula, that's the thing. It's okay. How would you manage this patient?
First, I would take. I would approach this patient according to the care for critical ill patient.
But he's not critically ill, is he?
Yeah, what?
He is not critically ill, is he?
Yeah, no. He's
okay.
a clinic patient. Yeah. How I would take full sets of blood, including full blood count, urea, and electrolytes, CRP, lactate, to know what's the level of infection or inflammatory in this patient. Also, I would order abdomen CT scan with IV contrast for this patient.
Why?
Yeah.
What are you looking for?
To confirm my diagnosis.
Which is what?
Colovascular fistula.
Would the CT scan with IV contrast show the colovascular fistula?
Yeah.
Okay.
Or we can see the thickening and the gases in the bladder itself in cases of colovascular. Yeah.
Excellent. So you cannot see the fistula, but you can see bubbles of gas inside the good.
Yeah.
What are the commonest reason in general for gas bubbles inside the urinary bladder?
The commonest cause of.
By the way, these are all very common FRCS questions. This is exactly how it works, and I don't want to say these scenarios probably are past FRCS scenarios.
Okay.
So they are all real questions for the exam. I'm not making this up.
Yeah, no, it's okay. It's okay. I'm fine. I'm happy about it. To break the ice as a starting.
Yes, absolutely. You need to get a feel how it feels. You don't want to experience that for the first time in the exam.
Yeah, exactly. Yeah.
Yes. Okay. So what's the commonest cause? You know that. Urine catheterization.
Yeah. Common is common. Yeah, exactly. Yeah,
yes. Okay.
Yeah.
Right.
Yeah.
So that's why.
It came to my mind to say any procedure, but I
Yes,
didn't
any
say it.
instrumentation, but the commonest instrumentation in the rear bladder is actually
Yeah,
ring
yeah.
catheter.
It's a full scope.
Yes, okay, that's fine. So CT scan can show that. Does it usually show the fistula? It can, but not always.
The sensitivity around the 85%.
Okay, all right. So you're going to do a CT scan with IV contrast. Okay. What else? If it confirmed that there is a fistula.
Okay. Also, the idea of CT scan also to rule out any colorectal malignancies, or what's the cause, or what's the initiation factor of a colovesical fistula? Is it diverticulitis? Is it colorectal malignancy? Yeah.
Would the CT scan show that?
Yeah, it can show masses in the colorectal. Also, I would discuss the case with the neurosurgery team. Also, I would discuss if the patient fit to do colonoscopy and there is no part of diverticulitis. I would go for
is it colonoscopy or flexible sigmoidoscopy, you think?
I would start flexible colonoscopy. Yeah.
Colonoscopy or flexible sigmoidoscopy? And what's the difference between both?
Flexible sigmoidoscopy.
What's the difference between both?
The colonoscopy, we check all the colon, starting from the anus until the cecum. But
so why? Okay. So if colonoscopy is more comprehensive than flexible sigmoidoscopy, why sometimes we do flexible sigmoidoscopy? What is the problem with colonoscopy?
It needs preparation.
Yes, excellent. What is the problem with the preparation? It can cause electrolyte imbalance in elderly frail patients.
Yeah, electrolyte disturbances in older frail patients. Yeah.
So for this patient, I wouldn't do colonoscopy, would it?
No, I would go for
probably flexible sigmoidoscopy. Yeah. What are you expecting? So, if you're referring to the endoscopist, what is the question they're expecting the endoscopist to answer for you?
To rule out a colorectal masses.
Okay. So the patient had a CT scan. He had a flexible sigmoidoscopy. It confirmed that there is diverticular disease. Okay, and we could see actually the internal opening of the fistula, and which coincides with the CT scan. So you could confirm that. What's the management? The patient comes to see you back in the result with his next of kin.
Yeah,
which is his son, and his son's asking you about. Now we know what is the problem. How are we going to treat that?
So the first step to treat any disease to know the cause.
Okay, so we know it's diverticular disease. We know it's colovesical fistula.
Okay, so I'm gonna explain to the next of kin what's the disease or what's the pathology, which is a diverticulitis, which is an outpouching in the colon wall, which can at some time can precipitate infection or inflammation because of stagnation of food, and in some cases this infection can cause communication with the other organ, which is the fistula.
How will you treat it?
Okay.
How will you treat this patient?
So at the meantime, the most important thing to ensure the safety of the patient, to admit the patient, give him some.
Why admit the patient?
Because the patient took 4 courses of antibiotic, and I think from this history, this is a resistant bacteria. I would call the microbiology team to discuss with them what's the optimal treatment, which I think would be an intravenous antibiotic.
So do you think the issue is that the patient was not on the right antibiotic, or the issue that the patient was on oral antibiotic?
This part should I take from the history?
Okay, yeah. Fine. So anything else? Any surgical option, any permanent option that you can offer to this patient? So the son here, I'll be the devil advocate. I'm the son here. I'm telling you, fine, the antibiotic will make him well for a while, and that will recur again because the main issue is here, which is the abnormal communication between the bowel and the bladder.
Yeah.
How we will fix that?
So I'm going to explain to the next of kin the treatment option depending on the performance status or the frailty of the patient himself or herself. Okay. So
how do you assess the patient's frailty, Sam?
According to the performance status.
What's the performance status? What are the grades of performance status?
So I do not remember exactly, but first the patient actively mobile. Grade 2, there is a restriction in movement, but the patient can do him or her daily activity. The third degree bound to the bed.
Okay. So
And
you
the
think
fourth
that patient's
single.
performance is a 3?
3.
Okay.
Any surgical or any treatment plan, depending on the performance status or the frailty of the patient himself. For example, if the young healthy patient came to me with this complaint and this picture, I'm gonna offer him surgery in form of Hartmann procedure and to do reversal later. But
So what surgery would you offer to, sorry, carry on.
So as the patient is performance status 3, I would offer him Hartmann procedure with colostomy, because already the patient is grade 3. I would offer the patient colostomy. However, I would discuss this with the colorectal colleague.
Okay. What's your subspecialty, Hassan? Sorry.
I'm upper GR.
Where do you work?
Royal Bolton Hospital.
Royal Bolton. It's okay. Is it Manchester?
Yeah, Manchester.
Okay. Fine. Okay. Fine. So you're going to discuss with the colorectal colleague, and you said, because just apart from his frailty, you would offer him if the patient is not frail, what would be the ideal management for him?
At the meantime?
Yeah.
Yeah.
So you said as the patient is frail, you're offering him Hartmann.
Yeah.
But if it's not for the patient frailty, what would you offer him alternatively?
So usually, if the patient medically fit and healthy, I'm gonna offer him once the patient's stable and the patient is.
The patient is not unwell, Hassan. Just to get out of the way, he's a stable patient. He's got that. He has been like this for 9 months, and he's all right. And actually, the son is challenging you. Say, well, my dad is actually just on blood pressure tablet. I am on more tablets than him. He's better than me. It's just his dementia. So the patient is not acutely unwell, just to get out of the way.
So the patient is a frail and stage 3. So
Okay.
I think it's not about a true or false treatment. I'm gonna offer the management plan. Okay.
No, I understand, and I agree with you on that. I agree with you. Okay. We're going to talk about this. My question is, if it's a 40-year-old fit and well patient who's got colovascular fistula, what would be the surgical management for him?
It will be a single stage operation, resection of the segment that causes the fistula, and do the anastomosis.
What is the name of the operation? Sigmoidectomy? No. It's high anterior resection.
Well, again, please.
High anterior resection. That's an
High anterior resection.
So that's why I want you to say I would offer the patient anterior resection, but as the patient is unwell, you would like to offer him Hartmann with an endocolostomy. Right. Now I'm the son and I'm telling you, my dad is defecating normally, and you want to give him a bag. How can that improve his quality of life? Would you mind offering him the standard operation, which is excluding the disease segment and joining him back again? What would be your answer?
I would answer him the idea of any surgery to return back of the patient to the preoperative status. Okay. So the patient is the performance status of the patient is grade 3. That means he's most of the time in the bed. Okay. So I think the colostomy will facilitate the process of evacuation of his bowel.
What is the problem of anterior section as opposed to the colostomy?
The first complication that we have, we're afraid to occur in this patient, which is a leak, which will be a disaster for the patient, like this patient. Okay, infection, bleeding, the physiological stressor from the anesthesia itself. Yeah.
Okay, that's fine. I'm the next of kin now, and I'm happy with your suggestion. Can you consent me or consent the patient for the operation?
I'm gonna ask if there is any previous documented or any let's say regarding the patient himself. What's the mental state of the patient? I'm gonna
The
assist
patient does not have capacity. The patient does not have capacity, and the son has got power of attorney. So I am the son with you. Please consent for the operation.
Okay.
Explain to me how will you do the operation.
This operation will entail excision or removal of the disease part of the colon that causes the problem, which is the diverticulitis. As I have mentioned before, it is an outpouching that can trigger infection, which causes the problem. We're going to remove this part of the colon. This operation will be under general anesthesia, okay, and it will be in open fashion, okay, there's some risk that it may happen, including infection, bleeding, failure of the stoma itself, like it can develop ischemia or bleeding. Also, I'm gonna explain that this patient, giving his history, this patient may need to stay in the ITU or HDU for certain time to make sure the patient has a good recovery. Also, I'm gonna emphasize that I'm gonna involve the stoma care team to teach or to learn the carer how to deal with the stoma. Yes.
What will be the follow-up after the surgery? What we're going to do after the surgery? Is there anything specifically you need to do? Any specific investigation?
After the surgery itself? First, I'm going to check the histopathology from the resected segment.
If you're not sure, that's fine. That's fine. Thanks, Hussein. Well done. Okay. I like your approach. I like your option. Okay. I like how you stood to your decision. That was the right treatment, actually. Few things that we can tweak, of course. Okay. First of all, this is a case. I gave you all the clues that the patient. First of, as I told you in there, why would a GP send someone with repeated UTI for surgery? Of course, it's colovacyclic history. Okay. You would start with a history. When it comes to someone without capacity, you have to check who has got power of attorney. That's something you have to mention in the exam. Okay, does the patient have capacity or not? Power of attorney. Performance status, you need to know. Performance 1, 2, 3, 4. That would be performance status 4. Okay, and I gave you the clue that the patient is bedridden all the time and he's all the time in a chair. So that's the thing. Okay.
Yeah.
And then you rightly suspected the commonest differential, which is the colovacyclic fistula. We had some discussion about, by the way, anterior resection, no, Hartmann operation, right hemicolectomy, these are general surgery operation, not colorectal. Yeah. You're expected to know this. This is in your curriculum as general surgery. The commonest thing I used to joke about it. I used to say colorectal is easy. It's either right hemi or Hartmann.
Yeah.
There's just 2 operations. Okay. Don't feel patronized, colorectal colleagues now. I'm joking.
It's not about the breast. Lots of trial, you know.
Yeah, but we all do, it's either one local mastectomy. It's just 2 operations. So anyway, but the right hemicolectomy, Hartmann, these are general surgery operations. These are not colorectal operations. Okay. Hartmann is the commonest operation done in the surgical take after appendectomy.
Yeah.
Right. So yes. So that's the colovacyclic fistula. Okay. You need to do bloods, as you said. CT scan. You need to know what would it show exactly, as you said. We needed a lot of prompting to come to the gas in the blood. It's very rare that you can see the actual fistula in the CT scan, actually, unless you're doing a CT scan with rectal contrast.
Yeah, with rectal contrast. Yeah.
So you have not mentioned that.
How about the cystoscopy? Is that any rule here?
No, you have to do flexible segmentoscopy.
Flexible
That's the first thing. You shouldn't have mentioned colonoscopy at all. It's right, because it wouldn't make any difference to me. It's not appropriate for this patient at all. Actually, it's flexible segmentoscopy so that you can visualize the fistula. You can see if there is cancer or not. CT scan is not the best way to find cancer if you're suspecting it. It's either colonoscopy, flexible segmentoscopy, or CT virtual colonoscopy.
CT colography, yeah.
CT colography, but not IVCT. Okay, IVCT is very rarely can show it because that connection will only show as a stranding, which you cannot tell if that's due to previous diverticulitis or is it due to fistula. So the ideal thing to start with, I would agree, CT scan is fine, but in the exam you have to be clear why you're doing that investigation. It's not to confirm that. You will confirm with the flexible segmentoscopy, but it can show masses. It can show if there is a gas bubble in the bladder. We do not usually do cystoscopy, but that's something you can mention. That you're going to discuss that with the urology colleagues to do cystoscopy if they need. Okay. And when it comes to the management, yes, I would agree with you. I would offer him Hartmann. Okay, and that's when someone will ask you, or either the next of kin, or the patient, or the carer. But that's not easy. Now you're giving him a bag. Why? When he can defecate normally, and that's when you have to be able to explain to the patient or to the next of kin that actually doing an anterior resection, which is the usual operation, that will carry the risk of either a leak, necrosis, intra-abdominal bleeding, okay, incontinence. These are all. And if it's very low, that means that we will end up having a covering ileostomy that might need another operation later on. However, the Hartmann is a simpler operation, and that will not affect the patient quality of life, as the patient does not go to the toilet anywhere. As a matter of fact, it might make the duty of taking care of him easier.
Yeah, exactly. Yeah.
That's how you should say in the exam. Okay? And when the consenting, please do not mention any medical jargon. Ischemia is a medical jargon. That's something you shouldn't mention. Infection is okay, but ischemia is not. And things like even endoscopy, we do not call it endoscopy. We call it a camera investigation. Okay. You are upper GI. You cannot say esophagus in the consenting.
No. Food pipe.
Gullet.
Yeah.
Food pipe or the gullet. But esophagus, for example, esophagus is a medical jargon. You do not use that.
Yeah.
So these things, people have lost marks in the exam for that. Okay. And just to sum it up, what you're going to do after, you have to put a urine catheter. And the catheter has to stay in for 6 weeks to make sure that the bladder heals. And you need to do a cystogram before taking out the catheter.
Before it's catheter and cystogram, yeah.
Yes. You have to do a cystogram first to make sure that there's no leak from the bladder before taking out the catheter. Okay? Thank you. Thanks, Hussein. Well done. Thanks, Hussein. Anyone has got any question about this scenario? Very classic FRCS scenario. And I hope that gives you a flavor of how things work, how the scenario work. I'm aware of the time, so let me just give you a last scenario before we talk about our course. Any takers? Any volunteers? That would be a quick one. Okay. Satyan?
Yeah. Hi.
Hi. Right. So you are in the breast clinic. Okay. What's your subspecialty, or where do you work, Satyan?
So I currently work at King's as our specialty is HPB.
HPB. Okay, great. So you're on the breast clinic, and you got a patient who came, and when you examine him, or you registrar examine him, you can see that. Can you explain to me what you can see here?
This looks like a biologically a male with bilateral gynecomastia.
Okay. All right. Okay. What is gynecomastia?
Gynecomastia is pathological swelling of breast tissue in males.
Is it pathological? Always pathological.
It can be physiological in old age or in teenage years.
Okay. What is the commonest cause of gynecomastia?
Commonest causes would be old age.
Okay.
Could be hormonal imbalance.
Okay.
Around puberty time, or
Right.
pathological causes could be something along the lines
What are the causes? Yes. What are the other causes of gynecomastia?
So alcohol excess in males, liver disease, pituitary tumors or testicular tumors, producing hormone excess.
Right. Okay. What else?
Medications, so exogenous.
What medications?
Sorry?
What medications can cause gynecomastia?
Quite often it's steroids,
All right.
especially in things like bodybuilders taking exogenous androgens for that purposes. Spironolactone.
Spironolactone is one of the commonest, isn't it? And what else?
Yeah.
Digoxin? H2 blockers?
Yes. Yeah.
Right. Okay. Okay. What else? Could it be a sign of a more sinister disease?
It can be a sign of malignancy.
What type of malignancy?
So we're looking at things like testicular tumor. I think in someone with a pituitary tumor could be related to maybe something like lung cancer with hormone-producing tumors.
Okay.
Could also be a primary breast, or if it's bilateral, it's unlikely.
Okay. Let me ask a question. Does gynecomastia increase the risk of breast cancer?
Not that I'm aware of, no.
Okay.
But I don't know.
No, the answer is no. No. Right. How would you manage this patient?
So I'm going to take a focused history, focusing on the duration of how long they've noticed this, and then what symptoms are associated with it. Is it purely that concerns are cosmetic, or is it so they have other symptoms like pain, discomfort? Take history a lot and do a focused examination of the breast tissue, testicles. Do a neurocranial nerve neurological exam. I'm going to organize a blood test for this patient, full blood count, urea electrolytes, liver function test. Also organize an ultrasound scan of the testicles along with a hormone panel. In the history, I'm going to take a focused history looking at.
Do you need to do any tumor markers?
For the tumor
markers?
So I can do prolactin, alpha fetoprotein,
okay.
FSH.
What are the tumor markers of testicular cancer? You mentioned testicular cancer, didn't you?
Yeah. So things like luteinizing hormones, FSH, beta HCG.
Excellent. Excellent. Beta HCG and alpha fetoprotein are the main ones. You mentioned alpha fetoprotein. Do you need to do any breast imaging?
I think it's in a bilateral master, unless you can palpate anything pathological, there isn't an indication to do anything at this stage.
What breast imaging can we do in male if we need to?
You can do a mammogram and an ultrasound scan.
Okay. Okay. So if it has been confirmed that it is benign gynecomastia, what is the management of this patient?
So if it's benign gynecomastia, then currently there is no surgical option available, I believe, on the NHS. So it would be sort of managing symptoms and potentially considering, hormonal treatment.
Hormone treatment, like what?
So something like tamoxifen could be offered. I think if the gynecomastia has been present for quite some time, so we're looking at sort of almost a year or so, it's unlikely to have significant benefit. But if it's more shorter duration, it may have some benefit.
Thank you. Thanks, Nathan. Excellent. Excellent. You can imagine how common is this as a short clinical case for general trainees in the exam. Very common. Okay, and they ask about everything. There is a long list of the causes of gynecomastia. They ask about all this list, this long list. Okay. Most importantly is the testicular cancers and more sensitive things. There is a very good summary for guidelines from the ABS, anesthesia breast surgery, for gynecomastia. I usually give it there. It's free online. It's called, if you just Google ABS gynecomastia, you will find it. They're just 2 pages, but they ask about everything in these 2 pages. Breast for general trainees is very special because it's all or none. It's either you know it and you answer it all correct and you get the full 8th mark, or you do not know it and you fail. There is no middle ground when it comes to breast for general trainees. That's why I always say it's very helpful to know breast very well. And also because breast practice in the UK is very unique. It's unlike if you practice it anywhere else in Ireland, for example, or in Europe or Middle East or anywhere else. But no, thanks, well done. Any question about this? Thanks, Stefan.
Quick question. Are we supposed to do a mammogram and ultrasound for these, or
exactly as you said? If it's clinically just gynecomastia, you do not need to do any imaging. However, if you're suspecting that it could be, we call it E3. We discussed that when it comes to the breast lecture. If it's anything suspicious, if you're suspecting it's breast cancer, you have to do ultrasound and mammogram. But yes, as you rightly mentioned, if it's clinically benign gynecomastia, you don't need to do any imaging. Okay, right. I'm aware of the time. I might be a bit 10-minute late if you would allow me. We're done with the scenario, but let me just go through that quickly. So we've discussed some scenarios. We've discussed about the FRCS. Let me tell you just in 10 minutes about the course. Right? We have curated that very carefully over the last 4 or 5 years. We've been consistently evolving to reach the current shape that we do now, which we believe that works for most people. So it's more than a course. We are very aware that it's not the cheapest, but it is the best value compared to what it offers. How it works, how it runs, how is it different to anything else? So we run it over the period of 3 months. Okay. Usually, what happens during the week, there are 2 lectures, 1 or 2 lectures about a topic. So every weekend there is a topic. It's the general surgery, then trauma and critical care, then breast, HPV, upper GI, transplant, everything. We even cover endocrine, vascular. There is something separate about radiology. Okay. With every week, it will be 1 or 2 lectures during the week. Okay. Every lecture is about 2 hours. There are some things I'm guilty with breast. I give about 8 hours or 9 hours. Okay. Because I am expecting that no one knows about the breast. So I get it from the ground and build it up. And then over the weekend, Saturday and Sunday, it is over Google Meet with a mentor, and you have to participate with Viva, even if you do not know. You would only know by practicing. So you get Viva about the topics of this week, and you get to watch others Viva as well. And you learn from both. You learn by doing, you learn by seeing. And that goes over 3 months. At the end, we do a mock exam, okay, which mimics the real mock that you're going to have, the real exam that you're going to have at the end, and you get feedback, okay? During the week, I'll go through that. So that's why we call it. It's a mentorship program rather than just a course over 3 or 4 days. We do gradual and systematic introduction of the topics. We believe that 3 months would be enough to prepare for the course, as long as you stick to the schedule that we have done already. Okay. You learn by doing. There is one-to-one mentoring at the end. That's optional. That's extra for those who need it. Most people, they don't need it, but if you need it there, if you think, I had that problem and I want someone to give me a proper assessment over that, or that's my weakest spot, then that's something we can offer that's extra. Okay. There is library that we can offer. There is a special application called the LMS that you have access for. We put library for all the available resources, which is a very big problem when it comes to FRCS, because there is no like textbook that you can study, not companion, not cracking. There is no set book for that. So we try to get the up-to-date library that is relevant to your subspecialty and put it there. Even sometimes when it comes to breast, for example, there are 2 libraries. There is one which is just relevant to the general trainees, and there is something else which is more relevant to the breast trainees. Okay, and all these sessions that we give are recorded, and you can go to back later. It is only accessible through the application because we are very aware of the copyright and downloading the materials and all that. Okay, what not to expect from this course? Spoon feeding of knowledge, that you go there knowing nothing, and we tell you everything that you need to know, and then you will find it all in the exam. That's not how it works. If you're expecting that, that's not that. We cannot teach you the whole surgery in 3 months. It's too good to be true. False reassurance. We do not tell you, don't worry, you're good, you're fine. And then you go to the exam to find, oh, actually, no, it's worse than what I expected. The constant feedback that we get, that actually the course is more difficult than the exam. And we get that in the mock. So when we mark the mock, we are very vigorous. When I tell you that in the mock exam, you got 5 out of 8. That means this is the lowest mark that you will ever get with the worst examiner. Okay, you can get better, but you will not get worse than that. So we don't give false assurance. Don't expect that we will cover everything. We cover the most common topics. And more importantly, we do not cover the whole knowledge. We try to teach you how to answer the question. We give you the techniques. And more importantly, as you practice, you get desensitized to the stress, as I explained. If you're going to go for that, how to get the most out of it. Sincere commitment of all sessions. We publish the whole schedule 3 months ahead. We understand that you will not be able to participate for all the weekends. But what I would expect you to be able to participate most weekends, okay, to get the best of it, you have to participate for your subspecialty. If you are HPB, you have to do it for the HPB weekend. If it's colorectal, you have to do it for the colorectal weekend. You go the schedule ahead, swab, do the swabs, everything, but you have to do it yourself. Okay? Try to do active participation online and offline. Sincere efforts from day one that I told you, you spare time to do the course. You don't study FRCS in your spare time. You spare time to do that. Okay. There is chat groups, and it's not the WhatsApp group. We have got a dedicated Telegram group. So during the week, even when you're not in the lecture and when you're not the Viva, what we try to do is we post regular scenarios there in the Telegram, things that you can answer in between the cases in theater or in between the cases in clinic or in your lunch break. And these are all relevant to the FRCS. And also, we are available there to answer your question. If you got a difficult case, if there is a question in the previous question, you think, oh, well, you'd like to know what is the best way to answer that, you post your question in the Telegram and we answer it there. Okay. This course is a very good opportunity to know each other. So even outside the course, I believe it's a very good opportunity to interact with each other, communicate, network, and you can form your own study groups, guys. It's very helpful. Okay. You can review your own videos. You can see how you answered everything, and you can spot your own problems. Okay. And more importantly, you can learn from how others answered that question. We give blunt feedback. We give grading the candidates, so you will get formal feedback every month, telling you what are your weak points, what are your problems, how you progress. Okay. We do extensive Viva training, so you get at least 3 to 4 hours every weekend. And for a specialty, we do separate Viva for them. So if you are breast, for example, I will spend with you about 13 hours in the morning. But if you are a general trainee, I will spend with you as a breast faculty just 3 or 4 hours, just covering only what you need to know. So there are small groups. We have to make sure that everyone participates. Okay. Mock exams we talked about, we are all available. I always make fun about Manny Camden, our course director. I tell him, I think Manny, I haven't met him personally myself. I keep telling him, I think you would be an AI, Manny, because he's always available 24/7. I never texted him once, and he took more than 3 or 4 hours to answer back. Okay, and you're approachable. So if you think midway that, oh, I'm struggling, I do not know, should I sit for the exam? Should I postpone it? We're all happy to go with long chats, phone calls. If that's not your first attempt, you'd like to go through your feedback, we do that very happily. Okay, we've got 24/7 IT support. Okay, any problems accessing the app, any problem accessing the sessions, that is managed very promptly. Okay, this is how we mark you every weekend. So you get a proper markup which mimics that for the exam every weekend, mentioning specifically what is your problem. If you failed, what did you fail for? And you get, we're a very long list of faculty. As I said, we've got about 20 or more than 20 faculties. So you interact with different types of examiners. And if you find that you get the consistent same feedback from all the examiners, probably that tell you that you've got a real problem here that you need to work on. We get monthly report, as we said. This is a sample for the report that you can get, telling you over the last month that has been your problem, that has been your performance, and that's what you need to work on. Okay, with the mock test, you get a real mock test. As it said, the constant feedback that we get from the mock test, oh, it's too harsh. That's fine. That's what we'd love to hear. We would like you to walk to the exam feeling that's easier than your mock, rather than feeling that's harder, or the mock has been very, very easy. You get a proper mock test report. Our course is accredited by the Royal College of Surgeons of Edinburgh. Okay, you get a CPD certificate. The CPD will be given based on your attendance, not subscription. So we have to calculate how many hours you actually attended, not subscribed. And with participation, I'm very sorry, we are very strict with that. If you're participating in the Viva, you have to keep your camera on all the time, or at least when you're answering. Okay, if you're not joining in for any reason, you cannot get CPD for this, and also you have to submit your feedback. Otherwise, you cannot get a CPD certificate. But that's created by the Royal College of Surgeons of Edinburgh. I think we're the only one who's got the accreditation. I might be wrong. Okay, and at the end, you get a certificate of completion with the CPD hours. Okay. Some candidates mentioned that they could claim the fees of that course from their study leave budget. That's something to say. I'm not sure about that. That maybe if you need any support from us to show that you have participated or paid or anything like that, feel free to reach out. Some candidates have managed to claim that money back from your study leave budget, from your hospitals. Okay. Yes, and as I said, we calculate exactly how many hours you actually attended, and we have to give you that exact hour. It's not like a form for everyone. Okay, this is not the actual schedule, but that's how the schedule will look like, as I said. So the first one would be orientation. I think that would be first week. We'll start in next week, and then would be general surgery, critical care, upper GI, breast, HPB, academic. Statistics, colorectal surgery, transplant, endocrine, and we've added something for vascular and radiology after, and then you get the mock exam. Okay, the mock exam would be 1-to-1. It will not be in front of everyone, so it would have to mimic the real exam. Apart from the Vivas, these are the rapid review lecture. Again, this is an example from, I think, our 9th or 10th course. Okay, that's how it looked like. There would be one for critical care, one for trauma, 2 for breast, Okay, apogee eye, transplant, everything, and we have added one for radiology as well. It covers most things. What you need to know, not everything. Okay. Our results have been consistently high. As you can see here, these are the published cumulative average pass rate. The national average here, as you can see, amongst UK trainees is 88%. If you're not a UK trainee, the pass rate is about 44%. Okay, and that's cumulative. The first attempt is less than that. So this is the average pass rate for non-UK trainees up for the 4 attempts that you have. And this is the overall cumulative national average. And these are our results compared. So as you can see, it's consistently high, especially among the non-UK trainees, which we pride ourselves with, is we understand the challenges and the limitations. And that's what we try to address. And that's why I think we've got one of the highest non-UK trainee pass rate. Okay. With the mock schedule, it would be something like this. This is what you get here. We get general surgery, 1 long case, 2 short case over 40 minutes, trauma and critical care, academic station, and specialty. Your specialty over 40 minutes. And that mimics the exam, and you get real life scenario. And this is just to give you a glimpse, how would it be like? It's a very intensive 2 weeks for the mock that we carry on. We got actually some candidates who have not been in the course, but they registered just for the mocks, just for the sake of that. This matches the schedule that you will have for your real exam. Okay, everyone has got their own slot. Okay, this is the total cumulative hours spent on the one of the sample of its course. Usually it goes higher than that, not less than that. You can see here general surgery is about 20 hours. With 44 hours, with lectures up to 54 hours of lecture, and that's why we say it's. I know it's probably the most expensive course, but that's the best value based on what you get. The LMS is learning medical system, which is an app that you can download from Google Play or App Store. I think there's a Windows app now or Mac OS app as well. It is a very sophisticated app. And when we started this course about 4 or 5 years ago, we have been very strict against recording anything, just because of the concern that this material could be leaked and then loses its value. And that's why we have so many restrictions on the application. It's ready for you. You can access everything. You can review the library resources. You can review the recorded videos, but you can access it only from one device at a time, either your iPad or your phone. If you would like to, if it's in your phone and you would like to study from the computer or the app, that's fine, but you then have to deactivate your phone. And every time something is downloaded, it will stop you from doing that. And screenshotting is prohibited. Anytime that screenshot is taken, that had to be reported there to the admins. We had to do that in order to be able to deliver what we deliver, in order for you to have more than 80 hours of lectures to go through again. Otherwise, it would be late. We all know it. Okay, and this is how the Telegram group would look like. It would look something like this. This is from our 8th course. So it is got islands like this, and we post usually questions, scenarios, and we expect you to participate. Even if you don't know, you're welcome to go look for the answers and answer it, because we're not just testing your knowledge, we're testing how you answer it. And you are free to post any questions anytime. You will always find someone to answer. That's why they say it's not just a course, and that it's over 3 months we are approachable. And we know what we're doing. It's not about giving you the best knowledge. It's the best knowledge that you need for the exam. That's why sometimes you might have a difficult case. For example, you post on the Telegram and our answer would be, look, this is the answer, but this is how you should answer it for the exam. Okay, so it's mainly exam focused. Okay, and that's me done. Sorry for running late, and I hope you found this session today helpful, and I'm happy to take any questions if you've got any. Did you find it helpful today? It's great. Yes, Hussein. You're muted.
First, thank you for this lecture. I subscribed for the course, but I have a question. As you told us, 50% from our marks from our subspecialty. I had to look at the schedule. For example, the upper GI in mid-August. So, what's your advice regarding the plan of studying?
Okay, so your upper GI, for example, Hassan. Okay, you should not start studying upper GI now. Okay, I'm sure you know that already.
Yeah,
you've got the knowledge already. Okay, my advice. Okay, during the week, you're not just studying for a day or two. What you should do is like that. You are in work every day. You finish at 5.
Yeah.
Okay, you've got busy home with lovely kids, with wife. You need to go and look after them. After you finish at 5, don't go home. Stay in the library in your hospital for 45 minutes. Okay, during the days, okay, you should go through your upper GI stuff. There will be a day or a couple during the week, okay, when you have the lecture. Attend the lecture. The lecture is not interactive. Of course, you're welcome to put any question, anything, but usually we lecture you. So that will give you some knowledge. After the day after the lecture, don't study your upper GI. Study what you got during the lecture.
Yeah.
Okay? And then, during the weekend, usually in that evening of that weekend, you will have, let's say that week is for breast, Hassan, okay? And you've got 2 lectures of breast, or 1 lecture that would be on Tuesday. So Monday, you're studying upper GI. Tuesday, you had the breast lecture, okay? You're studying upper GI and then you had the lecture. And then Wednesday, you're going through what we discussed in the lecture, in the breast. Wednesday, you're going back to upper GI. Thursday, upper GI. Friday, you're upper GI, maybe. Or maybe if you think the breast is your weak points, give it another day or 2, okay? Over the weekend, Saturday, go through the breast. And then in the evening, you're having the Viva of what you studied during the day.
Yeah.
Does that make sense?
Yeah. So you have to focus on your subspecialty. Yeah.
Yes.
Yeah.
And because I think it works best because it's very hard for you to make yourself a good tight schedule for 3 months. We have made that for you.
Yeah.
Okay. So if you just follow that strictly, that would be great. The other thing is you subscribed. You know exactly when is your upper GI weekend. Never miss that for any reason, Hassan.
Yeah, sure.
If you're on call that weekend, swap it.
Yeah, sure, yeah.
That's my advice.
Sure.
Okay?
Sure, yeah. Sure. Thank you.
No, that's you're welcome. There's something else I wanted to tell you, but I forgot it now. Yes. What I would say, not just for you, when someone comes and asks me, someone chat to me over the WhatsApp or anything. By the way, if you're in the group, I am on the WhatsApp and I'm happy to be contacted anytime for any reason. When someone contacts me, say, look, Mina, I don't know, should I sit for the exam or not? I ask them one question. What about your subspecialty? Are you confident in your subspecialty or not? If the answer is yes, I would say, go for the exam. If the answer is no, I would say no, postpone it till you are happy with that. One of the things is, I think one of our weakest points all is academic and statistics. We're not statisticians, and some of us do not work in a tertiary hospital, and we have not done PhD. That's why we feel it's our weak point. And I have seen candidates who spend about a month just going through statistics and everything. If you are clever, do your math, look at the mark. It's only a single Viva station. Okay? If you fail that completely, you can still pass the exam. It doesn't make sense to spend all that. And actually, we pride ourselves when it comes specifically to the statistics academic. This is Manny who gives these lectures. His lectures are amazing. I sometimes go back to his lectures, going through them. Once you go through this, you will find that statistics academic Viva is actually your best thing. That's your guaranteed marks. But what I say, usually it doesn't make sense to waste all that time just going through all these things when it doesn't count as much when it comes to marks. I hope that makes sense. Okay? Saqib, yes.
Hi, thank you for the presentation. My question is that, for example, I'm on call and I subscribe to this course and I make all the lectures. Is there a way that I can go on the app and revise them, or?
Yes. Everything that has been given is recorded on the application.
Okay. Perfect.
Everything is recorded. You cannot download it.
Mhm.
Okay. You cannot access it from two apps, but you can switch apps. So let's say you are using your iPad all the time for studying, but you are commuting for an hour work and you would like to play the lecture while you're in your commute because you missed it. You contact the admin team and they swap your login to the phone. That's not a problem. But you can access it from one device at a time. My personal advice for the lectures specifically, do not count that I will go and revise them and listen to all this again on the last 2 weeks before the exam. That's a lot to go through. The best way to benefit from the lecture, listen to them, make your own notes, and then you can go back to your own notes when you are revising just 2 weeks before the exam.
Perfect.
But yes,
Thank
you can, of course. So everything is recorded.
Thank you.
Yes, welcome. Any other questions, guys? Okay, if that's all, we'll wrap it up. I hope you found today helpful. Got any question about anything, I'm very happy to be contacted myself or my colleague, Mr. Catterville, and wish you all best of luck. Take care. Thank you. You're welcome.